I hope we are not too boring for you, because we are not dealing with the electrophysiological studies of muscle function. It might feel like a step backward to middle age, but hopefully you will stay with me for the next 20 minutes. This talk is not about one single study, but there is a bunch of study underlying this topic. It goes about neuromuscular function, which is from our point of view neglected so far, the adaptive force. Let's take a short look at the at the schedule. Firstly, I'd like to mention some unsolved mysteries in motor science, then to lead to that what we mean with adaptive force. After it, I'd like to tell and present some results about measuring AF, adaptive force, in the lab and of course under clinical circumstances. If there is time, I would give a brief look at the neurophysiological requirements to process AF. And finally, we ask what factors are able to influence AF. This is our road, and let's go to some mysteries. One enigma is the term functional weakness. Functional weakness means reduced strength, but without myopathology and without neuropathology and without satisfactory etiological explanations. There are many examples in the daily clinic practice, for instance, psychogenic functional weakness, or Ugo mentioned fatigue syndromes. Fatigue syndromes appear connected with infections or after surgeries, or with fibromyalgia. And they are frequently combined with other health issues. Functional weakness appears after intensive care. There is a fixed term called ICU acquired weakness, intensive care unit acquired weakness. And currently we have more than 60% of the survivors of Corona ICU dealing and struggling with functional weakness. In this case, pathogenic genetic affections are discussed in terms of deoxygenation or medication. Functional weakness appears due to endocrinal diseases, for instance, with the thyroid, adrenals, or pituitary gland. And there is a good paper from Michael Hurley, which discussed functional weakness as a prerequisite of orthopedic conditions. This is one of the mysteries in motor science we didn't solve so far. And in sports medicine, there is another one, the so-called non-contact injuries. What's going on when athletes injure themselves on their own without any impact from outside? Ruddy from Australia is to cite with, there is an abundance of research that has attempted to identify risk factors for injuries. But the conclusion is, however, there is a level of confusion. Nobody knows exactly what's going on. And indeed, there are nearly 72% of ACL ruptures, knee injuries in basketball without any contact from the outside. So how can it work? Garrett and colleagues tell us to this point There are a variety of non-contact or indirect injuries, but there is only one thing in common of all those injuries. The injuries appear when muscles develop tension while lengthening. This is the core point of all these injuries. Muscle injuries occur due to lengthening actions, but they cannot be provoked by shortening. Though the lengthening action might be the most interesting point regarding these injuries. This leads us to the second point, adaptive force. We think this is a motor function all of us do every day, all the time, but it seems to be neglected. What is meant with it? One example, to decelerate, dropping down after a jump. The muscle works as a brake. Or every time when we step down downstairs, which each step we have to absorb our body weight, the muscle is working backward. Or another example, when we go skiing, we have always to hold the body against the incoming forces from the ground. And these are only 3 examples for it. To make clear what we mean, let's do a short thought experiment. Imagine you have a bucket, a big bucket, and you hold it like this. At first, the bucket is empty, and then it will be filled with water. And we have an increasing load. To hold it stable, the subject has to adapt to the changing load all the time. And that's why we call it adaptive force. In case the load exceeds the subject's maximum holding capability, like in this case, there will naturally be a point of yielding. The muscle yields from isometric to yielding. So to summarize, adaptive force comprises, from our point of view, firstly, a holding isometric phase. And in case the maximum holding force is exceeded, it yields subsequently into an eccentric phase. This is what we do every day, maybe 1,000 times. From our point of view, 2 questions arise. Question 1, at which force does the yield start? Or in other words, what is the highest holding capability? And secondly, what about the force during yielding, during eccentric phase? This leads us to point 3, measuring and clinical testing of AF. We constructed devices to measure this specific capability. On the top, we have a device to measure elbow muscles, and on the bottom, we have a device measuring knee muscles. And we are grateful to Ugo to get the opportunity to publish some works on it at the EGTM. The mechanism of our devices are founded on pneumatic principle. As you can see, there is a bellows cylinder, and the air can produce force and motion. One trial runs like this. The machine is pressing against the subject, and the subject is able to decelerate the motion for a little moment. And right now, this week or next week, we will have a paper exactly on this trial on adaptive force of elbow extensors. Let's see on results of exactly this trial. This is the measurement of the same muscle of the same persons with two different trials. The red line shows the subject is able to hold the position. We have a angle torque plot, and the angle firstly stays stable up to a breaking point at a considerably high force level, and then the muscle releases, it yields, during release, the muscle is able to increase the force further on. So we have a maximum force during eccentric and a breaking point, the maximum holding force. A different trial is shown in the blue line. Firstly, the arm is working towards the machine, but the breaking point is at a considerably low level of force. After it, the muscle releases up to a maximum force, which is nearly the same one. What we can see, there is a maximum holding force at a considerably low level. The average of all subjects is shown here in comparison to the maximum voluntary isometric contractions, MVIC. And as we can see, the maximum during eccentric phase is nearly the same like the MVIC, but the maximum holding capability is substantially lower. In this case, the muscles start to yield at 75% of the maximum force. That means the holding stability of muscles is substantially lower. To introduce or to use these measurements in clinical practice, the machines are too complicated, and so we try to find a possibility to do it in clinical practice. The advantages of manual muscle tests are they are quick, flexible, and we can test more than 50 different muscles. The disadvantage is the interpretation and the force application are subjective. And that's why we constructed a device which unites both advantages. It brings flexibility and objectivity together. So we can do the manual muscle test using this device between the hand of the examiner and the leg, the thigh of the subject in this case. Here are some results from measurements with this handheld device in the comparison of the same muscle under stable versus unstable conditions. You see on the top, the force, the device measures the force, but also the position in space. In the middle, we have the gyrometer signals and the first derivation on the bottom. The blue lines represent stable conditions. And as we can see, the gyrometer signals stay around the 0 line. Looking at the red line, we have a point, the breaking point of yielding. And the interesting point is the force when yielding starts. And so we can see there is a substantially low force at the breaking point. And there is another aspect, the onset of oscillations. Oscillations occur only during stable conditions between both persons. Okay, to summarize, we see again an unstable muscle begins to yield on a submaximal force level. And the maximum force is produced during yielding. What we have to realize is the muscle increases force but yields in length at the same time. And from our point of view and on the experiences we did with patients, this could cause instability of joints and maybe a risk of injury. So our experience is the same muscle can switch between stable and more unstable behavior. I'm not aware what the clock says. 4 minutes left? Okay, so I have to skip the neurophysiological requirements. I'm sure all of you know that know a lot about it. Maybe only this point. In contrast to pushing muscle action, a holding muscle action has to adjust the motor output exactly to the incoming force, including the need to solve runtime problems when the force input is changing. Okay, this will be skipped. Okay. Last point, did a look at possible factors which could influence adaptive force. And these are some of them. When we eat a delicious meal or a not so delicious meal, there are different senses in the game. For instance, gustatory signals, seeing, emotion, and olfaction. This was what we tried to check. For instance, olfactory potentials are seen after 300 milliseconds in the brain after smelling. We know that odors are closely related to emotion, and there is an agreement that emotion generate motor reactions. So that's why we did a preliminary pilot study with 10 subjects and investigated the adaptive force during different smells. You can use such sniffing sticks like these for a reproducible influence. These three colors represent three different smells, but at the same muscle. Above we have the force development. The blue and the green line show pleasant and neutral smells, and the red line shows the behavior under disgusting smell. As we can see, the force development is very similar, but below we have the deviation of the gyrometer signals of the red line. That means that the muscle starts to yield at a considerably low level of about 60% of AF max. And the average of all subjects shows the same. We have round about 60%. At 60% of maximum force, there is the breaking point. A similar study, preliminary pilot study, is to imagine, only to imagine food. So we can imagine a delicious food, and most of us remember a horrible, disgusting food. And we asked the subjects to imagine these different kinds of food. This is an individual experience, and so it was individualized. On the left side, we have the lines of stable muscles during, you can guess, during the nice, delicious food. And we have no deviation of the thigh, whereas under unstable conditions under disgusting imaginations. The yielding starts in this single case at 45% of maximum force. Okay, oscillations too. To summarize, the average of all subjects shows the same. On the right side, we have the level of the maximum holding capacity at, again, 60% of maximal force, which is reached under tasty conditions. Okay, last aspect. We see the thalamus at the hub of the regulation of adaptive motor control, and from our point of view, nociceptions could be very interesting, and there are a lot of occasions to have nociceptions. And this is a single case study of a 63-year-old man with acute painful inflammation of the foot. The red lines represent the measurement, and as we can see, we have the same maximum forces after recovery. The thigh stays stable, but under painful inflammation, there is a breaking point at, again, about 60% of the maximum. So always the same behavior. Our conclusions, there are some indications that affecting afferences could possibly influence motor control, especially regarding holding and decelerating actions. And this could possibly lead to improper muscle function under load. And finally, in case of further scientific approval, this could be used for individualized diagnostics and possibly could help to solve mysteries of motor science. Okay, thank you for your attention, and with this brief view on a part of the University of Potsdam with a nice surrounding. Thank you very much.